So first thing, we're going to just check the hamstring range of motion, hip range of motion, and you can see it's not even 90 degrees. So then we're going to go to the feet. So in treating the feet, there's a bunch of different things that are important to do. First, check dorsiflexion, and you can see hopefully that the right one dorsiflex better than the left, and ideally people should dorsiflex passively to at least 110, 120 degrees easily. Otherwise, when they stand up, they get thrown backwards and there's compensation above. So, and then flexing the toes, they should be able to flex individually and independently of the ankle moving. So a lot of times when you flex the toes like this, you'll get plantar flexion of the foot, which indicates more tight toe flexors. And then plantar flexion of the foot, and you can probably see hopefully that these toes are tighter than these. And it's really important, this extensor digitorum brevis and extensor hallucis brevis can be very tight and affect how the whole foot works. So first we'll work on the dorsiflexion of the foot. So I put the massager on the bottom of the foot, hold on to the Achilles tendon and stretch it that way, and then put the foot on some dorsiflexion and just hold until there's a release, which will take probably about 15 or 20 seconds, hopefully. And generally, in my experience, I would say almost every single person, the left foot has more dysfunction than the right foot. So as it releases, I'm taking up the slack, still continuously pulling on the tendon. I'm right above the insertion of the Achilles tendon. And it seems like stimulating the tendon area where it inserts in the bone has a bigger effect on relaxing the muscles than just treating the muscles directly. And you can see we've gained about 10 degrees, at least it's past 90, which is good. And also there's more plantar flexion of the toes. Often, if the toes are restricted going into plantar flexion, all the muscles of the bottom of the foot and the calf will tighten up trying to pull the toes down. So often treating the extensor digitorum brevis and extensor hallucis brevis will get a release of the muscles on the bottom of the foot, which is happening right now, and the calf, because they don't have to fight against this tight muscle. And the extensor digitorum brevis and extensor hallucis brevis are hardly ever treated, but they're actually probably one of the most important two muscles in the foot, because when they're tight, all the rest of the muscles have to fight against the tension, and these, the extensors, and will tighten. So I'm perceiving a release, and we're almost to the full end range of the toe metatarsal joints here. And there goes the whole lower leg relaxing. So we'll recheck, and you can see there's a little bit more dorsiflexion. And what I'm checking now is anterior and posterior glide of the talus in the tibia and fibula. I'm checking both. The right's a little bit tighter. Also checking plantar flexion of the metatarsal cuneiform joints, and the right foot's tighter. Although generally speaking, in most people the left foot is tighter. What I'm going to do is thrust on the metatarsals in this direction And sometimes you'll get a pop, sometimes not. And that helped release a little bit more towards more dorsiflexion, which we'll work on here. So, massagers on the bottom of the foot. I'm pulling on the tendon again, right above the insertion in the calcaneus. And what's happening now is we're getting some relaxation in the hamstring. What I'm going to do is directly go up to the areas in the calf that are tight. And I'm essentially squeezing the muscle between my hand, my thumb, and a couple of my fingers, just up to tissue resistance, and not very hard. Although, to the person on the table, it can feel like it's hard, but that's only because when muscles are tight, they're more sensitive. And it'll always feel like I'm letting go when the tissues release. And I don't change my pressure, it's just the sensitivity changes. And we got a little bit more freedom. And you can see we've gained quite a bit more from 90 degrees. And what we'll do is see if the hip changed. And we gained probably another 6 inches in hip flexion. And the plantar flexion of the toes is pretty good. So what I'm checking now is for eversion of the forefoot and also adduction. And this is really important in all phases of walking. Most people do not evert the forefoot, so when they walk, they end up pronating the whole foot instead of just having the forefoot contact at the ball of the big toe. And so that causes extreme stresses on the ankle and knee. So what we're going to do is put the massager on the bottom of the foot, put my hand on the lateral foot, push into adduction and also eversion, and stabilizing cuneiforms and navicular. And so all the motion happens within the metatarsals and cuneiform junctions. And just overpressure and vibrate and wait for the tissues to release. And ideally, when you do this and you get results, you should end up being able to move the foot into full end range of anatomical motion. And so we're getting a release of increasing eversion of the forefoot. The adduction component tends to be more stiff, and it takes more time to increase adduction of the forefoot. And there it goes. And you can see, hopefully, there's more eversion of the forefoot. There's a little bit more adduction, and there's a restriction right here. And this might be a ligament connecting the cuboid to the fifth metatarsal. That's a little bit shortened. And so I'm contacting it, pulling it towards the toes, which is stretching it, and then vibrating, which is allowing it to release. And you can see how that moves better. You can feel the difference, right? Now, there's a restriction right here, and I'm going to pull it down towards the heel and put a little bit of adduction, stretch on things. And there it goes. You can see how that's freer. And what I'm going to do is just work my way to each cuneiform and metatarsal. I've never done this before, but it seems appropriate. There we go. And also what's happening is the bottom of the foot's relaxing. And you can see how there's more movement. So there's a principle that muscles are tight for a reason. And usually muscles are tight because whatever they're trying to do is not happening, and so they tighten up, trying to make whatever they want to happen. And in this case, by releasing the connective tissue, that is restricting the adduction of the foot, the muscles of the bottom of the foot and also the calf are relaxing because the foot is more mobile. And doing that also increases the ability of the foot to dorsiflex. So what I'm going to do here is to work on the posterior glide of the talus. And what I do here is to put a small cushion underneath the back of the tibia and fibula and just push the whole ankle complex posterior while vibrating my hand, and just vibrate until I feel a release. And again, what's happening is the muscles in the bottom of the foot are relaxing. And ideally, the anterior and posterior glide of the talus within the tibia and fibula should be equal back to the posterior and forward to the anterior. And there's more freedom here, although it needs a little bit more. It's about 20% different between going posterior, which is more restricted, and going anterior, which is freer. And right now I'm putting significantly more weight and pressure on the talus and navicular area, pushing it posterior. And that's a little bit looser. And you can see how the toes bend even more in plantar flexion. The forefoot still doesn't move down into plantar flexion enough. And what happens here is that the metatarsals are somewhat superior in the joints. So what I'm going to do is stabilize the cuneiforms with my thumb on the bottom of the foot, hold the cuneiforms up here, and with my right hand get at the bases of the metatarsal and shear the metatarsals this way to get them in the center of the joint. And again, apply vibration. And with my right hand, I'm actually putting it on my thumb, on my left thumb, so I'm increasing pressure this way on the cuneiforms, and then double-handed on my index finger the right and pushing down on the metatarsals to get the metatarsals centered in the joints so they'll have proper motion. Often glide of the joints of the foot is restricted, and by restoring glide you'll actually get better overall joint motion. And again, as you restore the glide in the metatarsal, cuneiform, cuboid joints, the bottom of the foot, the muscles there will relax, because what's happening as you restore neutrality in this joint, the muscles that have been formerly working hard to get the foot to plantar flex will just relax because of that new established joint relationship. So once again, I'm going to thrust on the foot. I'm contacting the bases of the metatarsal and pulling them towards the plantar surface. And you may be able to see how there's more motion, and the motion is freer, less blocked up. And what we can do now is to use the hammer and dowel, and I'm placing the dowel at the base of the cuneiforms. And that's a little bit more free. Now what I'm going to do is place the dowel at the bases of the metatarsals and drive them towards the plantar surface. It was all with the idea of trying to establish a neutral cuneiform metatarsal joint position. It's tender. And there's more dorsiflexion again. What I'm going to do now is just treat the tibialis anterior . And this has a trigger point there and a little cable of tight muscle. And often when the tibialis anterior is tight, it's a dorsiflexor. The plantar flexors of the foot and toes will tighten up also. So often when you treat the tibialis anterior, you'll get increased dorsiflexion because the plantar flexors don't have to counterbalance the tibialis anterior. go. So we gain another 5 degrees or more of dorsiflexion. So we need to do a little bit more in the forefoot eversion, also plantar flexion of the forefoot. And with this, what I'm going to do now is vibrate, stabilize the cuneiforms and navicular, and grab the metatarsal heads and essentially distract the whole joint area here. And the way I do that is to place my hands so the thenar eminence is on the navicular and cuneiforms, and sort of pry my hands like this, which then will separate the joint. Now hold this for a little bit of time. Get the vibration into the foot. And what I'm feeling is the fourth metatarsal is not having enough glide towards the plantar surface, and we'll address that in a bit. And I sort of am by putting more pressure with my fourth finger on the base of the metatarsal. And now there's a freedom at the end range. There's a lot more springiness, which is better than this hard finish that we were feeling before. So now more adduction of the forefoot. I'd like to see it at least another maybe 10 degrees going that way, and that will make a big difference on stance. The forefoot will actually be able to take its place in holding the body up, where many times the force gets along the whole arch and less on the ball of the big toe. By increasing the adduction of the forefoot, you get the big toe and the ball of the big toe involved in stance a lot more, and then less force is transmitted up to the knee and the hip if the ball of the foot supports more weight. So I'm really using quite a bit of force here because this is pretty stuck, but it's slowly starting to creep to more adduction. And you can see, hopefully there's more. There's still some restrictions right along here. And it's important when you palpate is to feel where the tissue is restricted, and that way you can treat the correct place. So what I'm doing is just again holding the foot into adduction, then the forefoot into adduction and eversion, contacting the restriction in the tissue, and just waiting for a release to occur, which is happening right now. And that's better. And the dorsiflexion is better. So now, what I'm checking is the ability of the calcaneus to evert, and there's less eversion on this calcaneus. And the importance of eversion, a lot of people have inversion of the calcaneus, and so when they do heel strike, they hit the outside of the heel, and as a result, when they come to pronate and shock absorb, they end up really, the whole foot everts too much, and it puts a lot of stress on the medial arch. So if you can get the calcaneus to evert more, then heel strike is more centered on the heel, and there's less force of coming into eversion of the whole foot. And also, if the forefoot is able to evert, the ball of the big toe will hit first instead of the whole arch absorbing the force. So the technique for this is just grabbing the calcaneus, put it overpressuring into eversion, vibrating, and sometimes I'll put eversion on the first ray and some adduction of the whole forefoot, and just hold it until there's a release. And I'm taking up the slack as it really releases. And I'm also, with my index fingers, doing a little bit of pressure on the insertion, lateral insertion of the Achilles into the calcaneus. And there we go. So with the calcaneus, you want to palpate eversion, inversion, rotation of the heel. There's a little bit of restriction moving the heel like that. And I'm not sure what the name of this is called, but taking the heel, pushing the front of the heel to the toes and then away towards the knee. And so what we can do is sort of stack all the different restrictions. In this case, restricted inversion, restricted side bending this way, and also restricted going that way. So by doing the restrictions in all the directions, it saves time. And there it goes. And often when you do all this stuff to the foot, you'll get significant changes in the knee in terms of a balance between the valgus and varus movement, rotation in the tibia to the femur, tenderness along the medial collateral ligament and lateral collateral ligament, where previously they might have been tender. Once you take care of the foot, all that will go away and be much better. Because often, if the foot can't conform to the ground surface, you'll get excessive twisting forces and side bending forces and medial bending forces in the knee, which cause strain on the ligaments and muscles trying to stabilize the knee. And what's happening now is we're getting some sort of rotation in the knee as the knee muscles relax. And so the calcaneus takes a while because it gets a lot of force on it. And it's quite possible that the ligaments stiffen because of its malposition, and then they stiffen to stabilize or protect it from the excess force. But generally speaking, once you treat the foot to increase its mobility, it will maintain it. Because a lot of what we're doing is in the soft tissue and not really treating muscles. If we're just treating muscles, the muscle tension would tend to come back. But treating soft tissue and getting it to lengthen and getting the joints to function properly will generally remain. So that's a little bit less stiff. The heel itself is more mobile. There's still a little bit more we need to do in eversion. And it's really important to spend the time until it's done. And many times, really getting the foot mobile, that's much better, will have a profound effect on everything above, because if the foot is not mobile and can't conform to the ground, other places above will start compensating. So by treating the foot, now we're going to pull the toes. By treating the foot, often tensions above that have been compensating for the foot will just release without even touching them. And that's a much better glide, although it doesn't fully go backwards as much as it should, so we will do that a little bit more. And again, supporting the tibia and fibula, and that way my pressure can be exerted at the talus. And notice my thigh, I'm putting a little bit of dorsiflexion on the foot. My hand is cupping the talus and just putting probably 30 pounds of pressure or more at the joint, and just vibrating, putting the vibrator in my hand and waiting for a release. And I'm increasing the little force on dorsiflexion, because often a talus that's jammed up between the malleoli has restricted dorsiflexion. And what I'm going to do now is, besides the anterior to posterior pressure on the talus, I'm going to put a little bit of superior to inferior pull to open up the mortise joint, and then increase a little bit more dorsiflexion pressure with my thigh. And there it goes. And I'm increasing the dorsiflexion and releasing. And that's much better. The end range is a lot smoother and less blocky. And we've gained a little bit more in dorsiflexion. Now, what I'm going to do here, you can see, ideally, the toe muscles, the toe flexors, should be independent of the ankle dorsiflexors. But as I do this, there's an increase in pressure to get plantar flexion. And so there's quite a few tender spots in the back of the calf. So what I'm going to do is put the entire foot into dorsiflexion, and also the toes, and just contact some of these little trigger points in the back of the calf that relate to the toe flexors. And as I do that, there'll be less resistance to dorsiflexion at the toes. And also, many times, if the toe flexors are tight, it will also prevent the soleus and gastroc from really loosening. So by treating the toe flexors, you'll actually get a change in the whole posterior calf area. As you can see, possibly we just had a release in gastroc and soleus. So there's a couple things to think about when people have restricted dorsiflexion. If it's bilateral and people can't get to 90 degrees easily, and actually they should go to 110, 120 very easily, is that when they stand up, the tibia has difficulty being perpendicular to the ground. And as a result, there's a tendency for the tibia to be pushed backwards or pulled backwards by the gastroc and soleus and possibly the toe muscles. And then as a result, there's compensation above to get the body weight over the feet. So often in low back problems, neck problems, getting increased dorsiflexion in the ankle and in the toes will greatly eliminate the tension in the low back and the neck. Also, if one side is restricted in dorsiflexion, the other one's normal, when people walk, when they bring the restricted dorsiflexion foot through from toe off to the next heel strike, normally what happens in the phase where the foot clears is sort of equal to the other leg, you're pulling your toe and ball the foot into dorsiflexion so the toe doesn't drag along the ground surface. If the toe and foot doesn't dorsiflex enough, people will end up leaning away, tightening up usually the quadratus lumborum on the opposite side to enable to clear the foot. So often by getting increased dorsiflexion in that restricted foot, after the dorsiflexion is restored, the quadratus lumborum on the opposite side will be significantly looser. And what's happening now is I'm almost able to get to 90 degrees with the toes in this amount of dorsiflexion of the foot, which is what's supposed to happen. There we go. And so the bottom of the foot's really loose now. There's much better plantar flexion in the forefoot and in the toes. There's a little bit of restriction in the connective tissue on the top of the foot here. So what I do is vibrate my wrist, stretch the toes, and find the restricted tissues above the metatarsals, and usually I push the tissue that way while I'm stretching the toes. And when I stretch the toes, it engages the tissue I'm contacting with this hand, my left hand. And it's releasing now. And that's better. We're going to find another spot. And that's much better. Another area that people have problems in is either a structural or functional bunion. And there's quite a few people have a functional bunion where their foot is adducted, their big toe is adducted pretty significantly. But if you passively move the big toe, it will actually, the phalanx will be in line with the metatarsal. So there's not really much joint damage. And what happens is a lot of times people will have joint pain, but the adductor hallucis trigger point right here refers pain to the first joint. And basically muscles are tight for a reason, and that the adductor hallucis is trying to bring the phalanx past the line of the first ray. And often there's a restriction in the joint capsule right about here that is exquisitely tender. And again, what I do is put the massager on my wrist, find the tender spot, and then overpressure the phalanx into more adduction and wait for the tissues to release. So getting the phalanx of the big toe to go past the line of the metatarsal is really important for a more stable stance. And also having the toes to really be able to plantar flex is really important for a stable stance, because the toes are really important in maintaining balance and controlling sway of the body. So what I'm doing is finding the little tiny spots. They're about, the tissue is probably about 1 millimeter by 1 millimeter square, but it can be very, very tender. And I just hold until the tissue releases, and then find the next spot. and continually overpressuring on the phalanx into adduction. And I'm just positioning it in different positions of dorsiflexion of the big toe and plantar flexion. Often people, when they will go from dorsiflexion to plantar flexion in the big toe, the toe does not move in a straight plane. It often goes into adduction or abduction depending upon the pulls and restrictions in tissues. So that's a little bit past the line of the metatarsal. And when I'm doing this, there's a clunk, and also the toe is, as I go into dorsiflexion, really wanting to go into abduction. So what I'm going to do is put it into dorsiflexion, adduction, and then find the restriction. In this case, it's on the bottom of the toe, and get it so that when we go into dorsiflexion, it maintains the plane and doesn't go into abduction. And it's releasing. So another aspect of treating the big toe, not only to get the metatarsal phalangeal joint so that you have more adduction, and when you go into plantar and dorsiflexion, it maintains a plane of movement and it doesn't deviate laterally or medially, is to also palpate the distal joint. And often, in most people, you have abduction of the distal joint is a lot easier than adduction. And again, it's important to get a balance between adduction and abduction. So again, overpressuring, finding the tender spot on the joint capsule. I put the massager on my wrist, overpressure the distal toe, big toe, into adduction, and find the restriction. And what I'm also going to do is check for rotation, lateral, external rotation, medial rotation, and there's a restriction in external rotation and adduction, and we're getting release. So it's important to get the distal toe to be able to function better, and so that it can actually support the weight it's meant to support. Because often all the portions of the foot are such that it enhances overpronation of the whole foot, and that is a problem. So by getting the distal toe to go into adduction more and the metatarsal phalangeal joint into adduction, the toe can actually get into adduction or neutral and support the weight it's supposed to support. And you may be able to see now we're actually getting past the line of the metatarsal with fairly good ease. There is more to be done in the big toe. What I'm going to do is yank on it and also hold the toenail and then just do it this way. Distract it with slight amount of plantar flexion to give some space in the joint, in the distal joint and the metatarsal phalangeal joint. And that's relaxing. And also the flexor hallucis brevis is relaxing on the bottom of the foot. And it's working better. When I do this, there's a far less tendency to go into abduction, AB. But what I'm going to do is work on that just a tad more, getting at the base of the joint on the plantar surface, getting beyond the connective tissue at the bottom of the foot into the joint connective tissue. I'm pulling the toe into adduction and dorsiflexion. And there we go. We're getting a release. So before the tape runs out, what I'm going to do is talk about a couple other things. One is the plane of the metatarsal phalangeal joint of the big toe. It should be parallel to the ground, and a lot of times when you palpate into external rotation, internal rotation, they aren't balanced. In his case, there's less external rotation. And so ideally what happens is that when the toe goes into dorsiflexion and plantar flexion, the axis of this joint should be parallel to the ground. If not, if there's a tendency to go either easier to external rotation or internal rotation, when there's flexion of dorsiflexion and plantar flexion, you get a lot more stress on the medial joint surface, and it can be a factor in creating actual structural bunions. So what you want to do here is, again, in his case, there is decrease in external rotation. I overpressure the external rotation. I'm at the cuneiform that intersects with the first ray, and just putting a little bit of plantar flexion, adduction of the big toe, slight adduction of the first ray, and mostly external rotation of the first ray. And wait until we have a release. And I'm feeling a little spot right here that's restricted. And there we go. So there's a better end feel to external rotation, although it needs to be going some more. And we can work on that later. Another thing to do is palpate the fibula for anterior and posterior glide, superior glide, inferior glide. And what's interesting is a lot of people will have chronic sprains between, and so typically it's this ligament here. And in the process of an inversion sprain, the ligament will pull on the fibula, so the fibula essentially is inferior. And so often the superior glide of the fibula is restricted. So you can do a number of things. Get right on the styloid process of the fibula, push superiorly, and then also palpate for posterior glide, anterior glide, and combine the two movements. And so my thumb is doing superior glide and posterior glide, and I'm just applying the massager onto my hand to impart a vibration to the tissue. I'm increasing a little bit more posterior glide to the fibular portion here, and there we go, we get a release. And what also happened is the whole foot relaxed. And it's not much, but it's still palpable, and there's a little bit more posterior glide that needs to be done, and we'll do that. And as you can see, truly treating the foot takes a bit of time, but it's well worth it because the feet are the foundation of the whole body, and often there's lots of compensation that occurs because the foot does not move properly and does not conform to the ground surface. And the more flexible and malleable the foot can be, the less strain there is on the joints above. And one more last thing for chronic sprains is the peroneus longus is always tight on people. It's probably the second tightest muscle in the body next to the teres major. And so you get right below the head of the fibula and release that trigger point. And then there's the peroneus brevis and tertius, which need to be released. And once the trigger points are relaxed, the muscle will actually respond faster to inversion stresses and actually be stronger. trigger points in muscles tend to weaken muscles and slow down their reaction time. So getting rid of the trigger points will enhance the muscle's function and generally prevent the chronicity of, in this case, of repeated sprains. So you can see how there's more dorsiflexion, better toe dorsiflexion, much better plantar flexion. The eversion of the calcaneus is good. Same with the forefoot. Need a little bit more on the adduction of the forefoot, but in general, there's quite a bit of change in the foot and increased function. And we'll take one more look and see if that actually helped the hamstrings. So we gained about a foot without even touching the hamstrings.